The goal of our treatment, as I mentioned, is to really make all agents available to all patients. Unfortunately, after a long period of no treatment options with overall survival benefit in a third-line setting, now we do have relevant options. I mean, before we used FOLFOX followed by FOLFIRI with the addition of antibodies, bevacizumab and EGF receptor antibodies, but now we have new classes of agents, new agents that can really improve survival, and based on actually phase 3 data with regorafenib and TAS-102, which is an oral fluoropyrimidine, actually fluorothymidine. So those oral agents have shown efficacy in a third and even fourth line setting for unselected patients with metastatic colorectal cancer. Then there are the more selected options for patients with the BRAF V600E mutant tumors and the immunotherapy for patients with MSI high cancers.
We've gone through 2 lines of therapy, sometimes 3, but for most patients now we go through 2 lines of therapy. If you're on the right side, you go chemo-bev, and then you have the decision or the thinking about, should I go to regorafenib or TAS-102? Now in the RAS wild type, one could again think, well, should I consider an EGFR inhibitor first on the right side? Should I consider an EGFR inhibitor first before I proceed with regorafenib or TAS-102? I think the answer is a little bit more complex. We haven't seen a lot of signals with EGFR inhibitors on the right side, and I think you introduce perhaps regorafenib before cetuximab or panitumumab. And then we have this data from Japan, from the reverse trial that looked at regorafenib first followed by cetuximab first followed by regorafenib. And the study, although underpowered, did reach its primary endpoint of showing a survival benefit if you move regorafenib ahead of cetuximab. So on the right side, I think I feel very comfortable having regorafenib in the third line, and then I will consider actually after regorafenib TAS-102, and then perhaps cetuximab. On the left side, and those patients with RAS mutations or those patients with BRAF mutations, HER2 amplifications, say. For the HER2 amplifications, let's table that discussion, because those patients probably should go on a clinical trial with HER2 target therapies, TKI plus trastuzumab. So this is a very separate subgroup that probably is a little bit complicating. But for the other patients that may not be eligible for EGFR inhibitors, then you go bev chemo, and then your third line is either regorafenib or TAS-102. There's no discussion about an EGFR inhibitor there. How do you choose between regorafenib or TAS-102? Really depends on looking at the globality of the data. We recently presented some data, and this is now accepted into publication to the oncologist, that looked at all the randomized trials with TAS-102 and with regorafenib, including the REDOS trial, which looked at the dose escalation strategy of 80 to 120 to 160 on a weekly basis, which we've shown was a superior strategy to 160. When we look at the cumulative knowledge with regorafenib and TAS-102, what becomes clear, well, there are a number of things that become clear. From this analysis, it becomes clear that regorafenib with a dose escalation strategy is superior to regorafenib 160, but also may be superior to TAS-102 in terms of outcomes. Not reaching the level of statistical significance, but enough to say that this essentially is meaningful, at least clinically meaningful. The other pieces of data come from having a large amount of data coming from subset analysis from multiple studies. And when we look essentially at the studies that were done primarily in Asia, like the Concur and the Terra, what becomes apparent to us is that from the cumulative knowledge is that regorafenib seems to have a better effect if we expose patients to it earlier, as indicated, rather than later in the refractory setting. And that's true for the Concur trial. The Terra trial tells us that TAS-102 keeps its activity regardless of pre-exposure. Then Reverse tells us, or confirms somewhat, although it still needs to be confirmed in the US, and we have Reverse 2 that will be ongoing in the US. We do need to confirm whether here, where they're moving regorafenib ahead of cetuximab, makes sense. But reverse also challenges us in the point of understanding that regorafenib seems to have a much better effect when you move it up, rather than let patients go through all the lines of therapy and use regorafenib as a Hail Mary effect. It doesn't seem to have much activity there. It seems to have more activity up there. So my preference is essentially in the sequencing of therapies is to go with regorafenib first, then TAS-102. On the right side, regorafenib, then TAS-102, then cetuximab or panitumumab. Now, the bigger question is of course, are there patients where you would move TAS-102 ahead of regorafenib? And the answer is yes. If you have a patient who has borderline liver function because of significant liver metastases, meaning that the liver functions look pretty upset, I probably favor TAS-102 as long as they're within reason. I mean, if they're very upset, then both drugs should not be given. I would also consider it for the patient who may have experienced significant hand and foot syndrome reactions from other agents, although this is again not the same reaction, or not even, I mean, it's similar in some aspects. But those are the patients that probably would not want to go through another agent that can affect them that way. Those patients may go to TAS-102. On the other hand, if your preference is to start with TAS-102 first, which I don't, but if your preference is to do that, then those patients who may have experienced significant bone marrow toxicity from other agents, those patients should probably not go on TAS-102, or should go with extreme caution, because TAS-102 can induce significant hematologic toxicities.